As the director of 2 care homes, polypharmacy is part of our quality of care and its reduction. I'm responsible for the quality of care. But it's not just the quality of care, it's a quality of life issue, a quality of life for my residents. I've seen dramatic differences in the quality of their life when the burden of the medication is reduced and they're on less medications. There's a number of challenges. Firstly, with my colleagues. Some of my colleagues have been reluctant to engage in the polypharmacy reduction. They find it easier to take the line of least resistance than perhaps deal with a long explanation or an argument with relatives. It's hard to get the topics fixed in their mind, for example, of the number needed to treat, the differences in the use of these medications in the elderly, and the benefits of reducing polypharmacy. Not just with my colleagues, but this extends across the care home with the care aides, particularly those on the front line. Some of them are reluctant to see the medications taken away, particularly if they're tranquilizers or other sedatives. But overall, the biggest issue is it's a system issue. It's hard for me to deal with individually, but all of us, I feel, should be looking at how we deal with medication in the elderly, from GPs, care homes, emergency departments, and hospital admission, and also at the transition points, which is really important. Oh yes, very much so. It's been very useful to have enthusiastic and interested key participants in the care of the elderly together in one room. We build on each other's energy. We learn from each other, and when everybody's together on the same page, we understand each other's problems, then we can go forward and start looking at meaningful involvement in the programs. No, it's been extremely useful. Well, the materials are still in development. They've been personally useful to me because I've been able to use them if there's a question from a colleague. But they aren't yet developed enough that I could hand them out to colleagues. They need to be both simplified to provide a summary, and they also need to have an in-depth review and bibliography that's available for my colleagues. I think that that's an important next step for us. I'd like to see the development of a multi-level marketing or advertising campaign for shared care. I'd like to see us take a lead from the very successful program of Bugs Don't Need Drugs. I think that that's changed in admin speak a paradigm. And the Shared Care Committee could help by bringing the key players together, by acting as a coordinating and also as a body that'll push us forward. You know, busy doctors, we sometimes feel that we've reached a certain point, but we need actually to be pushed to get even better at this. So reduction in polypharmacy. We need a change management approach, and we need people who are used to running change management to help us. Yeah, and this is exciting. The more people you meet from other provinces, just last weekend I met people from Saskatchewan who've sort of independently have almost, well, exactly the same ideas and are developing materials. We can share these, and if we have this as a movement across Canada, and the Shared Care Committee helping us to link these bodies together, we've got a lot that we can learn from each other, and ultimately apply for the benefit of our patients.